We're going to be looking at when and why to use isometrics, heavy slow resistance, and plyometric energy storage within MSK rehabilitation. So this is just a quick decision kind of flow diagram, looking at where the tissue is in the healing stage, what kind of injury it is, looking at pathology. So if the tissue or the injured site is highly irritable, it's in the early phase of injury, and you need some pain relief, we can start with isometric exercises. Now, if the capacity and alignment is needed, so strength building up the muscle size, tendon stiffness, we can progress to heavy, slow resistance work. If returned to fast stretch shortening and sports related kind of skills and chaos, we can do advanced to plyometrics and energy storage. Now let's start off and talk about isometric exercises. So we normally use these in the early stage of tissue healing and the early stage of rehabilitation. This is when the tissue is irritable and the pain is quite high within that injured site. So we need to have pain relief there without provoking movement, especially with tendinopathies and some muscle strains. We also use isometrics when joint shear compression must be reduced. So this is an acute ligament sprains or a reactive tendon. Now, why do we do isometric exercises? It reduces pain short term, it maintains neuromuscular drive and early load tolerance without putting a large load through it. Also, it provides a bridge to isotonic work. Now, how do we do isometric exercises? What is the typical dose? So normally 30 to 45-second holds, 4 to 5 reps. We can work off an RPE of 6 out or 7 out of 10, and we can do it to 3 or times a day for analgesic phases. Now, how do we choose joint angles? So we choose pain tolerant mid-ranges, and we progress to lengthen angles later. Now, this can be performed daily. We can monitor the 24-hour response from these exercises. How do we progress isometric exercises onto the next stage of rehabilitation? We do it when the pain is 2 out of 10 or less during the exercise, and then it goes to baseline by the next day. The patient is able to tolerate longer holds and more challenging joint angles without flaring up that injured site. And then we're ready to introduce controlled isotonic work. What are the problems? What are the pitfalls of isometrics? Now, staying on isometric exercises for too long, we'll get a poor strength and power carryover. And maximizing effort early in reactive tendon, we might see a next day stiffness spike. So let's talk about heavy slow resistance work. So we use this in mid-phase, so during proliferation and early remodeling. And we use this kind of work to build strength, stiffness, and capacity. Now we use this, for example, in tendon rehabilitation once reactive symptoms have settled. And then we use it in muscles after early protection phase. Now we use it when you need fiber alignment and tissue-specific mechanical signals. Now, why do we do heavy slow resistance work? Now, high time under tension drives collagen synthesis and alignments within tendons, and it works with strength and hypertrophy within muscles. It improves load capacity before we start introducing the next phase. Now, what is the typical dose of these heavy, slow resistant exercises? We normally do 3 to 4 sets at 6 to 8 reps, and we use a slow tempo. We normally do it 2 or 3 times a week per target tissue, and we have 48 to 72 hours between heavy sessions, especially within tendon work. Now, exercise selection matches the tissue line of stress. So, for example, different types of calf raises for Achilles, leg press and squats for knees. Now, when do we progress this exercise onto the next level or the next stage? So normally we use clinical measures such as ROM and strength and pain. So ROM between 5 and 10% of the other side. With strength, we look at 80 to 90%. That is obviously context dependent. and we look at the pain during the exercise and how long it takes for that pain to return to baseline. And when we're actually ready to add energy storage, plyometric work, and speed exposures. Now, what are the downfalls and the pitfalls of using this type of exercise? Advancing load, volume, and speed at the same time, we can cause spikes. And obviously, not having enough recovery between heavy tendon sessions can actually increase morning stiffness. So let's talk about plyometrics and energy storage. Now, we use this during late remodeling and return to sport phases. So the athlete must be able to tolerate rapid loading, deacceleration, and change of direction relevant to the sport. Now, after adequate capacity from high, slow resistance work, the strength and tissue tolerance should be established. Now, we use this type of exercise because it restores rate of force development, leg stiffness, and energy storage release qualities. It trains neuromuscular control under speed, which links well into the complexity and kind of the chaos of sporting movements. Now, the typical dose, we start with bilateral submaximal contractions, so things like pogo jumps, line hops, and then we progress to unilateral, multi-directional, and reactive drills. So we can do many different types of exercises within that, and then we can integrate intensive, so bigger areas, more kind of high slow resistance work versus intensive work, so acceleration, deacceleration, heavy small areas. Now we can progress when the strength is roughly 90%, so 10% deficit. We can do hop tests, we can use normative data, sports goals that is required obviously within the sport they're playing, and no 24-hour symptom spikes. And the task performance maintained under fatigue as well, because within a sporting context, that athlete will get tired. Now, what are the pitfalls? So we need to make sure that we have strength before we introduce this stage. Large jumps in contact heights or center of pressure kind of changes or direction can cause overload issues as well. Now let's look at the different types of tissue and kind of examples of exercises for each of these different types of tissue. So if we start with the tendons, so Achilles and patella, we can use isometric for analgesic and early tolerance. We can do heavy, slow resistance work. So we can do slow calf raises, squat kind of variants. We can then go into kind of our stretch and strength cycles. So we could do pogos, hops, and bounds. We can space heavy sessions between 48 to 72 hours, and we can monitor morning stiffness kind of trends with this type of tissue. So if we're looking at muscle strain, so using hamstrings and calf as an example, we can do early isometrics, and that will work in reducing pain in the protected ranges. We can do heavy slow resistance work, so we can do things including eccentrics and lengthening positions, and then speed exposure and plyometrics. Now we can use pain-free high-speed drills. We can look at strength symmetry, and obviously looking at a stable 24-hour response after these exercises. Now, if we look at ligaments, so ankle sprains or MCLs, we will do early isometrics around joint stabilization, so they can stabilize the muscles and protect that joint a little bit more. And then we do proprioceptive work. For heavy kind of slow resistance work, we work a lot with kinetic chain strength, and then we go on to plyometrics and change of direction, and we do that in a graded way. So we could use brace and tape as well to protect that joint a little bit more during stages of rehabilitation. So with cartilage or with patellofemoral joint pain, we favor kind of heavy slow resistance work with controlled compression ranges. We do careful depth and angle selection, and we can introduce low impact plyometrics late if tolerated. But we do need to watch for soreness, and especially if we're looking at the knee, especially in deep flexion. As with any kind of rehabilitation program, working with tissue healing phases plus the injuries, we always need a safety and progression checklist before we can move the athlete up to the next level. We use pain as one of these checklists and baseline pain the next day after the rehab program or performing exercises. We're looking for no increase in swelling or infusion or protective movement from that injury. We do use a lot of objective markers, so clinical markers, and we need to see that they are either improved or maintained. So we use lots of different things like ROM, strength, hop, sprint metrics, so we can make sure that the athlete can tolerate what they're doing and move on to the next stage. Another one that's really important is the athlete's confidence and how ready are they in performing those movements, and again moving up to the next stage of rehabilitation. If any of these items fail, we hold the athlete at that stage, or we can actually regress them, and we adjust one of the FITT variables. We normally retest in 48 to 72 hours or per tissue guidance.